two categories of patients that will benefit mostly from interventional medicine. So the first set is, yes, there's standard of care treatments available, but they're just not that attractive. If I have a bladder stone, I'd rather have it taken out by the natural route than to have abdominal surgery, cystotomy, stay in the hospital and recover. So there's lots of conditions for which there are standard of care treatments, but minimally invasive options are available and very attractive. And there's also the whole other set of patients, which I see on a routine basis, which standard of care fails us. There just are no good alternatives. An example of that would be an intrahepatic shunt. Just can't get in there surgically and tie it off. So what can we do for these patients? Can we offer them something? And that's where interventional medicine, because it can go in through the vascular route, respiratory, or urinary tract, are able to go and get into little areas that otherwise would not be accessible. Getting into the kidney by cystoscopy and taking stones out, avoiding a nephrectomy. All those things can be done through interventional medicine. So interventional medicine in veterinary medicine has really taken leaps and bounds in the last 15 to 20 years, as interventional medicine or interventional radiology in people has too. And right now in interventional medicine in veterinary clinics, we're almost at the point of having hybrid OR suites. And there's a couple of places that have now developed one. We're working on building one at the University of Montreal, where all the different technologies that you're seeing on the screen can be integrated into a surgical suite, so that the animal comes in, gets all the diagnostics, therapeutics, leaves, and goes home. So having a suite like this that's integrated, that allows endoscopy, ultrasound, CT, fluoroscopy, surgery, and laser surgery all at the same time. So that's really kind of a one-stop deal. However, before getting to this point, there was a history. And first, you needed to be able to start looking at animals and people. You needed to be able to do radiographs. And so in the 1800s, it took a while to develop proper methods in order to perform radiography. These are some of the early bounds. Followed by, in 1895, the first radiograph was taken of a human hand, which again was just huge strides at that time in radiology. And surprisingly, only a year later, the first angiography was reported. Chalk was actually injected intravenously, and an angiogram, so that the blood vessels, as you can see over on this side, are very visible. Thankfully, it was in a cadaver. It was not in a live person, in case you were concerned. If we go through history, how have we got really to where we are now? In the early 1900s, urinary exams were starting to be done, and they were using contrast agents to highlight the urinary tract. So that too really opened up the whole field of endourology in human medicine, because being able to inject contrast agents and guide them yourself through the urinary tract really improved diagnostics and led also to improved therapeutics. There's also femoral and carotid angiography that was developed a few years later also, that again just completely changed the way that vascular disease was treated in people. And it passed by starting to better diagnose conditions. In 1964, it's what's considered the birth of interventional radiology, in that there's Dr. Daughter and Cook. Dr. Cook, who went on to create Cook Medical, so it's the same Dr. Cook, did the first angioplasty. Now, what an angioplasty is going into a blood vessel with a little balloon, dilating the balloon in order to open the lumen of that vessel. And prior to the 1960s, if you had an occlusion of your femoral artery, well, the solution was to chop your leg off. It was amputation. And so you can imagine how impressive and exciting this was that Doctors Cook and Daughter were able to go in through the carotid artery or through the femoral artery with a little balloon, guided by fluoroscopy, open up the lumen, save your leg, and you were able to walk out of the surgery suite. So this was just an incredible development and advancement, and it really opened the door to the development of interventional radiology. I'll just point to the fact that there was some radiation protection at that time, but the results or the effects of radiation on the thyroid and lens were not really appreciated. In the 1980s and the 1990s, as you can see, a number of, there was huge leap forwards. There's really an explosion of different interventional procedures, both in human, and it also passed by veterinary medicine as a lot of the procedures were developed. And so stents that we use commonly today, lasers, CT, MRI, all of them were developed around that time, and again, really just created a specialty of interventional radiology and opened up the doors to so many procedures that we now commonly do in people and in veterinary medicine. And I'd say in interventional medicine, the organs that we most commonly treat would be vascular, respiratory, and the urinary tract. And certainly in veterinary medicine, as an interventionalist, probably about 85 to 90% of the patients I see are presented to me for different urinary tract interventions. The urinary tract is so easy to access from the natural route that it really lends itself well to interventional medicine. So in veterinary interventional medicine, really it's in the early 90s that some procedures were starting to be done, and really the early 2000s. So coiling of PDAs, coiling of shunts, placement of a tracheal stent was first done in 2002. And so there was starting to be a little bit of interventional procedures. And so that's kind of where I hopped in. So I want to tell you about Charlie. So in 2001, I became a professor at the University of Montreal, and I've always been very attracted to endoscopy and radiology, but I'm an internist by training, but I always like to kind of get in there and see for myself what was going on. And I did a lot of respiratory medicine, and Charlie was presented to me as a 10-year-old Pomeranian who in 2003 just had absolutely horrific tracheal collapse. You can see the video of the very, very severe tracheal collapse, and he was on tons and tons of medication, but he was refractory to all medication. He would walk into the clinic, turn blue, honk, turn blue. Everyone would get very, very stressed. We'd give him oxygen, and then we'd take him off oxygen, and then we'd sedate him, and then he'd turn blue again, then he'd collapse, and then he'd choke, and he really had no quality of life. And the owner asked me, well, Dr. Dunn, what can you do for Charlie? Is there anything to be done? Is it possible to do something for Charlie, or is it impossible? And at that point, there was this one case report of a tracheal stent with absolutely no follow-up, and the only thing I knew to treat tracheal collapse were medications. I said, look, don't really know if there's much can be done. There's this one case report. Otherwise, I use meds. We're kind of at this point now, I think you have to make a decision. And she says, okay, well, I'll make that decision. But I want to ask you one question. Is it possible to do something for Charlie, or is it impossible? There's no maybe, there's no in-between. Either it's possible or it's impossible. And if it's impossible, I will euthanize him right now because his quality of life is horrific and I don't want him to continue this way. However, if it's possible, then go ahead and do what you think is possible. So when an owner tells you that, you better be pretty sure that it's impossible. So I said, well, let me think about it. So I thought within 10 minutes because the dog was dying, and we decided, let's go for a stent. It's been done once before in a dog. It's done in people with tracheal carcinoma. It's done in children, the bronchomalacia. Why can it not be done in a 2-kilogram Yorkshire Pomeranian? Let's try it. So we went over to the human hospital. We got some little tiny pediatric bronchial stents, and we placed them. These are the little tiny pediatric stents that are kind of sutured onto a catheter. And by fluoroscopy, we were able to take that stent and put it into the trachea, put it approximately where the tracheal collapse was, and deploy it. And we actually needed 2 of those to span the length of the collapse that was a little bit cervical, a little bit thoracic, but mostly at the thoracic inlet, as you could see on the radiographs there prior. And Charlie actually woke up from anesthesia and was breathing fantastic and did really, really well for about a year and a half. A year and a half later, the owners called us to say, you know what, he's just not breathing very well, and I feel like the signs that he had before have come back again. So we had Charlie come back in, and we x-rayed him, and what we saw, where the arrow points, is actually a collapse, a broken part of the stent. So the stent had actually broken, as you can see on radiographs. And so we did bronchoscopy on him to kind of fully appreciate what was going on. And basically, the rungs of the stent had broken off and were poking into his trachea. And because the stent had lost its integrity, well, there was tracheal collapse that had come back again. And so the owner again said to us the same sort of thing: is it possible to do something, or at the end of the road and we euthanize? So we figured, well, let's just try to put another stent in there. If one worked, maybe we can just put another one in there and strengthen it. So that's what we did. And it worked. And Charlie actually went on to live until 16 years of age, when he then died of heart failure. And it's thanks to Charlie's owner that we were able to learn about tracheal stents, that we were able to, in the meantime, put other stents in dogs, and also learn how to treat a broken tracheal stent. And we went on to publish that. And this was way back in 2003. So a lot of times, leaps and bounds and advancements in veterinary medicine are really thanks to some of the owners that are there to support us and encourage us, and sometimes have us step out of our comfort zone. Certainly Charlie's owner I want to thank for definitely having me step out of my comfort zone twice. And to follow up with Charlie's story, we have Oscar's story. So Oscar was presented to us in 2005, 3-year-old, intact, male Kerry Blue Terrier. Oscar is a very, very sweet dog, but came in very uncomfortable because, as you can see on the radiographs, he has multiple stones in his os penis and was unable to urinate. He was stressed, forcing to urinate, just little blood-tinged drops were coming out. He's basically completely obstructed. It was very, very difficult to get a catheter in there. Those stones could not be repulsed at all. They were embedded. He had failed medical dissolution. And just to add a little bit more fun to everything, the reason they drove 18 hours actually to come to the teaching hospital, is they said, well, he kind of has this condition called hemophilia C that's been diagnosed in Kerry Blues. And when they tried to neuter him, he almost bled to death. And so he has a severe coagulopathy, so we were told that you're able to take stones out by a minimally invasive manner and avoid surgery. I had never done that before. I have no idea where they heard this from. But it was a kind of an interesting concept. And certainly in people, they were doing all sorts of interesting fragmentation of stones and that, and so decided, maybe there is something we can do for Oscar. Maybe we can, and avoiding obviously a urethrotomy, which bleeds, avoiding a cystotomy, because with just a skin incision, the castration was almost mortal. It was almost fatal. And so what we decided to do was go over to the human hospital that was using lithotripsy and see if we could borrow their unit, and so we did, and we brought it to our hospital. And we took a very deep breath, and we inserted a scope into his urethra, and we fragmented the stones with a lithotripter. So by looking at the stone, finding it, and then applying an electrical current, we're able to fragment those stones. And once the stones are fragmented, well, then it's much easier, because then you can just go in with these little pronged baskets and remove the fragments from the urinary tract. So you're avoiding surgery, especially for embedded stones. You don't have to go cut into the urethra or cut into the bladder mucosa. You can actually just remove them. And that worked really, really well. And it worked so well that we decided to start a clinical study in which we enrolled a bunch of different patients. And in 2008, we published close to 30 cases. And it was kind of interesting because some colleagues of ours in the States were actually working with a different type of lithotripter, a laser lithotripter. So both of us published these cases at the same time. And so really, it's thanks to Oscar that we started developing lithotripsy, and there's another group also that was working on it. So again, thanks to Oscar's owners, it allowed us to really kind of take lithotripsy, or take stones that were embedded, and a step further, and how can we go in there and remove stones in a minimally invasive manner? People don't have as many problems with bladder stones, they have more problems with kidney stones and ureteral stones. So the whole bladder lithotripsy at that point had not really been very well developed in veterinary medicine. So you all have sticks that are red or green, so I'm going to make you work again. So I have a question for you. This is a 2-kilogram Yorkie, or I should say the radiographs of a 2-kilogram Yorkie that has some dysuria, polyuria, hematuria. We see that there's a radiopaque stone in the bladder. It's quite large. Is it possible to remove this stone? He's failed medical dissolution without cystotomy. And may I add, he's too tiny to get a scope up the urethra. So if it's possible, use your green stick, and if it's impossible, use your red stick. So is it possible to remove this without inserting a scope through his penis because it's too tiny, without surgery? All right, I see lots of green, excellent. And just before I give you the answer, we have a kitty here. Is it possible to remove these stones and the plug that you see that's basically filling up the whole distal third of his urethra? Is it possible to remove that plug that cannot be retropulsed and we cannot get a catheter through there? Is it possible to remove that without doing a perineal urethrostomy? Is it possible or impossible? Green for possible, red for impossible. And not voting is not an option, unless you don't have a stick. All right, lots of green, excellent. So there's actually a technique called percutaneous cystolithotomy that involves a 1 centimeter incision, go access the bladder, put stay sutures on the bladder, do a stab incision through the apex of the bladder, insert a 4 millimeter trocar, and that allows us to really scope the entire lower urinary tract, even in very small patients, because in very small patients, like this little Yorkie, it's really just the penis that limits the size of the urethra. So you're able to get a scope all the way down there and clean things out. Even in male cats, you can scope almost the entire urethra. And so by doing that, we're making a teeny tiny incision at the apex of the bladder. We're able to go in there, remove stones. We're able to do laser surgery, remove tumors, remove polyps, and also go and remove those embedded stones, and even do lithotripsy if necessary. So this technique really gives us access to the lower urinary tract in a phenomenal way. And on top of it all, when all is said and done, we have a 1 centimeter incision that's closed up, and the animal can go home as soon as they've recovered from anesthesia. There's very little recovery because it's such a small incision. It's basically the size of a laparoscopic incision. So the answer to both of those questions is definitely possible, and this approach makes it possible. All right, so more work for you. This is a large, very, very large kitty that was presented to us for quite severe azotemia, chronic kidney disease, and had multiple stones blocking the left ureter. So left ureteral obstruction, very, very severe, did not respond to medical therapy. The azotemia was rising, chronic kidney disease, so even though the kidney on the other side was fine, didn't matter. Can we do something? Can we relieve this obstruction without any surgery whatsoever? And has failed medical management. Possible or impossible? Okay, so most agree that it's possible, and you're right. So how is it possible? Well, we're able to do cystoscopy on female cats. And if we're able to do cystoscopy, then we're able to identify the ureterovesicular junctions, or the ureteral papilla. And the ureteral papilla in cats are actually in the proximal urethra. So all cats, in theory, are ectopic, but it doesn't matter, they're not incontinent. So what you're seeing in the upper left-hand corner for you, there's two little holes. Do you see like two little dimples at the bottom? Kind of around 5 o'clock and 7 o'clock? Well, those are the ureterovesicular junctions in cats. And you can get a little guide wire in through that ureterovesicular junction. And once you get a guide wire into something, then you can do anything you want to that structure. And so we put these little pigtail stents. And so here we are into the ureter. We're able to go up into the kidney guided by fluoroscopy. So we have image integrated technologies. Fluoroscopy allows us to see that we're going into the kidney. We inject a little bit of contrast. The guide wire's looped into the kidney. And then we slide our double pigtail ureteral catheter up into the kidney so that one loop is in the kidney. The body of the stent goes through the ureter, and the other pigtail loops within the bladder. And then we just pull out. So now we've bypassed the obstruction because urine can flow through the stent or around the stent. So even though the stones are still in place, we've now relieved the ureteral obstruction. And the cat wakes up, there's been no surgery, and can go home the same day, unless fluids are required for the azotemia, and then we'll keep them a couple of days. But very minimally invasive, very little discomfort, and cats tolerate these stents really well. And here's just a radiograph of the stent looped in the kidney, looped in the bladder, and spanning the entire ureter. And this can be done in dogs, this can be done in cats, it can be done in ferrets, rabbits, all sorts of species. All right, another question for you. There's a 10-year-old female cat that unfortunately has been diagnosed with advanced transitional cell carcinoma. This carcinoma has invaded the trigone, most of the bladder, and the urethra, and the ureterovesicular junctions. So we have ureteral obstruction, and we have urethral obstruction. Can these 3 obstructions be relieved? Please vote. Green for it's possible, red for this is a little too much now. All right, everyone, there's very few reds. So it can be relieved. This is not minimally invasive, however. It's minimally invasive for the kidneys, but this is an abdominal approach. And what we can actually do is place 2 nephrostomy tubes, connected to a port, sub-Q, with a tube going into the bladder. So this is called a subcutaneous ureteral bypass. So it's basically bypassing the ureters and the ureterovesicular junction that's blocked. And so urine is taken directly from the renal pelvises, passes through the catheter, through the little port, and then the port's connected to a cystotomy tube so it fills the bladder. But the urethra is obstructed too. So in order to unobstruct the urethra so this cat can urinate what's being drained from the kidneys into the bladder, a urethral stent needed to be placed. Oops. There we go. By placing a urethral stent, before placing the stent, we see the urethra is filled with tumor. After deployment of the stent, it really plasties the tumor against the wall of the urethra and opens up the lumen and allows this cat to urinate. So honestly, 5 or 6 years ago, my answer to this question would have been, it's impossible. This disease is way too advanced. We have 3 obstructions. But interventional medicine, as we go along and develop our expertise, the goal is to find really treatments for patients in which there are just no good viable treatments. And this cat actually did very, very well for 8 months with chemotherapy, and then unfortunately died of metastases from the transitional cell carcinoma, but was not incontinent, azotemia completely resolved, and had a really good quality of life during those 8 months. And the owners were overjoyed to be able to have almost an extra year with their cat. And so this was a really good solution to a really bad disease and a really bad problem that I think in a lot of circumstances, and certainly a few years ago, we would have said is not treatable. So it's the beauty of interventional medicine is making what used to be untreatable, treatable. And again, because I won't let you rest, it's the end of the day, is it possible or impossible to treat a 2-year-old Great Dane that has just massive idiopathic renal hematuria? Wherever he walked, it was just an absolute disaster. It was scary. Every time he urinated, it basically was just fresh blood. And so the traditional treatment for idiopathic renal hematuria was taking the kidney out. Except that given that in about 25 to 30% of cases it's bilateral, is not really a good option to take both kidneys out. So is it possible or impossible to cauterize these lesions that are often ulcers within the renal pelvis that are bleeding without surgery? All right, I'm seeing mostly greens now. There's very few reds. So yes, it's possible. So as we accessed the kidney in the cat in order to place the ureteral stent, well, by endoscopy, we can again access the ureterovesicular junction, get a guide wire up there, do contrast, evaluate the kidney. All right. So I think we're at the point of having a balloon catheter block off the proximal ureter, and we injected a sclerosing agent within the renal pelvis that then just stops the bleeding, and we pull everything out, and the dog goes home. So again, what used to be a nephrectomy and invasive surgery and praying that the other side didn't develop a lesion has now become really a condition that is quite easily treatable. It's done on an outpatient basis. And so a lot of the cases I presented to you so far have been cats and dogs. But interventional medicine, really the limits there are no limits. And certainly interventional medicine in the last couple of years has expanded quite a bit to zoo animals, to companion exotic pets, to farm animals also. And when you think about it, our cats and dogs have tons to benefit from this type of minimally invasive approach, but so do a lot of the other animals. And so here are just a few patients that we've treated at the hospital in Montreal. Pot-bellied pigs. If any of you do exotics, you know that they're, especially the males, come in with urethral obstructions, very hard to treat. Usually cystotomy tubes are left. We hope the stone dissolves or it passes a spasm. Mortality rates go up to almost 75% in male pigs with urethral stones. Well, we're able to go in there through the percutaneous cystolithotomy approach, remove that stone, have it analyzed, and the pig can go home the same day. So again, much easier to manage and a much better prognosis in keeping them hospitalized for prolonged periods with cystotomy tubes. Horses also, especially cows and horses, the beauty is that they're so large that access into the ureter is actually quite easy. When you're used to getting into a cat ureter, getting into a horse ureter is pretty easy. And a lot of these procedures can be done standing under sedation with just an epidural. So avoiding general anesthesia in some of these large animals is really crucial to their well-being. And I'll just play some videos here. So on the bottom, this is a ureterovesicular junction in a horse. And so we've actually done a cystoscopy. We've gotten in there. We're just placing a guide wire in through the ureterovesicular junction. And this was a horse that presented in renal failure with bilateral ureteral obstruction caused by stones and bilateral hydronephrosis. Now, traditionally, what would have happened is the kidney would have been removed along with the ureter, but this was bilateral. So that's why the large animal people came to see me. And we intervened, and we were able to do both sides. And so I'll just show you, that's the laser lithotripsy. We're fragmenting the stone within the ureter of the horse. There were multiple stones. And once the stones were all lasered and the fragments were removed, we decided to go up and see what the inside of a horse kidney looked like, because why not? So that's on the bottom screen here. We're kind of moving up the ureter. We do it under continuous saline flush in order not to damage the mucosa, and always over a guide wire. And part of the image is blocked off a bit, but what you can see is we're actually inside the horse kidney, and you can see the calyces and that within the kidney, which allows us to do interventions within the horse kidney, again, while the horse is standing under only an epidural. So being able to go in there and sample pus, unblocked abscesses, and treat masses and stones within the kidney is possible now. Tortoises, reptiles, poor healing, cutting through a plastron is not very attractive. It takes over a year to heal. And so tortoises that are presented and aquatic turtles with bladder stones can now be treated by lithotripsy through the cloaca. And camels also get a lot of urinary tract stones that I've learned, and we see a number of them. They also undergo lithotripsy standing under epidural. Guinea pigs with stones. This is little Ella, who had a huge distal urethral stone, as you can see on radiographs. It was treated by lithotripsy. So it took 7 minutes to anesthetize her, break the stone, remove it until we woke her up. And if any of you are used to doing guinea pigs, you know that the length of anesthesia is directly correlated to death. And so we tried to really do this quickly, and Ella was up, eating, and out that evening, and did really well. Rabbits, lots of stone disease in rabbits, lots of nephroliths, ureteroliths, and we can also place ureteral stents in rabbits, like I showed you in the kitty also, to relieve ureteral obstruction. Goats, we saw that goats can be goat sat or pig sat, and goats, male goats, get tons of stones also, and so lithotripsy can be performed. All sorts of urinary tract interventions can be performed to give them hope. The latest publication on goats with stones is that only 16% survive to 1 year. So the recurrence of stones is huge, and our inability to treat them is huge, and so interventional medicine really, hopefully in the next few years, will change that as more and more of these procedures become available for goats. This is a goat, too, that strictured his urethra following stone disease, and we placed a urethral stent in there. So what you're seeing is urethral stent. You're seeing the rungs of the stent against the mucosa, and you're able to see the stent that has restored patency to the urethra on the left side.
We can't forget ferrets, who get lots of stones, and a lot of us that treat cats also treat ferrets. They too can benefit from interventional medicine. Stone removal by percutaneous distal lithotomy, lithotripsy. And we also see the occasional ferret with a tracheal stricture or tracheal trauma, and they can undergo tracheal stenting just like Charlie did. So what does the future hold for us? Certainly I'm very excited about the future. We've seen the past. I've presented what the present looks like in interventional medicine. What does the future present? Well, certainly I think nutritional interventions are going to be very, very important for us. And as in interventional medicine, we're there to treat disease. There's nothing less invasive than to prevent disease. And so I feel by combining interventional medicine with nutritional strategies and be able to prevent disease, then we'll really achieve our goal of being as minimally invasive as possible and restoring patient health in a minimally invasive manner. Stem cell therapy has been looked into quite a bit for chronic kidney disease. And there's also 3D printing of different implants. So a little bit customizing treatment. So not only putting a tracheal stent into a patient, but actually taking a 3D image of that, designing a stent that fits perfectly into that patient. So I definitely feel that that is where the advancements are going to be in the next 5 to 10 years in veterinary medicine. And also producing organs and replacing organs, such as this artificial bladder that basically has ureters and nephrostomy tubes that are integrated, certainly are being used experimentally right now. I'm hoping in the next couple of years we'll be able to use artificial bladders in order to remove cancer completely from the urinary tract. So lots of exciting things on the horizon. So interventional medicine, it's making the impossible possible. And I guess I'd just like to leave you with one thought that certainly helps drive me in my practice every day is when you've exhausted all possibilities, remember this, you haven't. Thank you.